Yeah, I'm just sharing the screen, sir.
Yeah, please do it.
So we have 5 OSCEs. I mean, it's close to 10 o'clock. So I will not take much of your time. Yeah. So I think all of you are going to answer in the chat box. Enumerate the principles of antibiotic stewardship. Or maybe the case presenters, they can unmute quickly. We have only 5 minutes. I don't want you to keep awake for long. Anyone answering?
I don't see any messages. Please, all of you, at least type one principle, if not all together. Yeah, we have one answer.
Policy per unit based, yeah, but some general principles, Sridhar. 5R, what is 1R? Aniruddha says 5R. Surveillance, I hope it is microbiological surveillance. Anyway, so I think I will just proceed for all of you. Need to, yeah. So you can remember this mnemonic, mind me. So first is always microbiology guides the therapy. So let us suppose I am working in a unit. I should know what have been the antibiograms of my previous babies. If my bug is, let us say, Klebsiella, and which is sensitive to amikacin, I will use amikacin. But my bug is Klebsiella, which is resistant, then I have to choose an antibiotic like Peptas. So it has to be microbiology based. I mean, always keep a tab on the antibiograms which you generated. Second, indication. I cannot start an antibiotic prophylactically for a central line. Always choose the narrow spectrum. If I'm suspecting a gram negative, it is always has to be something like an antibiotic like amikacin. Always look at the dose, and also it depends upon the site and type of infection. Minimize the duration. You cannot, let us suppose it is culture positive and it is not having meningitis. No point in giving for 21 days. And never give broad spectrum many antibiotics. It has to be monotherapy. So it is called as mind me, and it is important to know about this and also practice this. Routine surveillance cultures, it has such as no role, but I hope surveillance you meant as the microbial in the cultures. So this is a graph of a 30-year-old CTG graph, and she has been admitted with pain in abdomen. AFI is 2 to 3. Can you identify what type of decelerations and where do you see? Come on, quickly. Yes, Supriya got it correct. Sridhar got it correct. Variable, and where do you see it? Or compression. Yeah, correct. So this is not mirroring the contraction and it is something not related to. So it is a variable. I hope all of you would have seen this in your units. And it is one of the most important tool in the prevention of asphyxia. Okay. So early decelerations, I don't have the photograph, but it is with head compression and they're usually benign. Late decelerations are indication of uteroplacental insufficiency. Here it was a variable deceleration. Correct. So this is quick mathematics exercise, but let us see this. All of you need a pen and paper for this. In a study on accuracy of CRP for against blood culture, 75 units with positive CRP, among them 20 were culture positive. And there were 125 units with negative CRP where they had 5 culture positives. So the question is, calculate the sensitivity, specificity, positive predictive value, negative predictive value. I know it is quite late in the night. I hope somebody will be able to do it. So you need to first write a 2 by 2 table. I hope all of you are comfortable drawing the 2 by 2 table and then do the calculation. This is the most important thing, is to first draw 2 by 2 table. Okay. For the want of time, I'm not using the whiteboard. Just give me one answer. Just tell me sensitivity or true positivity. Okay, I'm sure it will take some time, but I will not. Okay, so this is what is called as a 2 by 2 table. So in our case, the screen test is CRP and culture positive. So how many were CRP positive? Among them, how many were deceased and how many were not deceased? Okay, this is how we create. I hope all of you are comfortable. Amongst the CRP negative, how many had blood culture positive and how many amongst the CRP negative had blood culture negative? So CRP positive, blood culture positive, CRP positive, blood culture negative. So these are false positive. So in our case, what happens? So amongst the CRP who were positive, 20 were culture positive and the remaining 55 culture negative. And in the CRP negative, 5 were culture positive, remaining 120. So what happens? The true positivity is these were the deceased. So amongst the deceased, how many had the screen positive? That is 20 upon 25. So the sensitivity or true positivity is 80%. What is true negativity? That means specificity. That means amongst the CRP negative, 120 where the culture was negative. So the non-deceased were this CRP positive yet culture negative, CRP negative and truly culture negative. So this is 120 upon 130. So it was 69%. What is positive predictive value? It means if the test were to be positive, what are the chances? So it means that the total CRP positive were 75, but amongst them the true deceased or culture positive were only 20. So it will be 20 upon 75. What is the negative predictive value? That those having negative and not having the disease or culture negative, that is 120 upon 125, that is 96%. Please, those who are exam going, spend some time to understand this, to assess a diagnostic test. This is very, very important. And all of you practice this as an OSCE question. Yeah. Anyone? What is this graph? Would have seen. Sorry, I gave the answer. Okay, this is an ROC curve, and what is on the x-axis and what is on the y-axis. All of you would have seen this, and this is one of the most important tools to assess 2 or more diagnostic tests and to draw cutoffs. Let us say somebody wants to say at what cutoff should I intervene. Let us say even for CRP, they have to draw a ROC curve. So what happens in the ROC curve? We just look at the true positive versus the false positive. So on the x-axis, we have the true positives, and the y-axis, we have the false positive. So higher the true positive and the least false positive. I hope you get it. And we look at comparing the ROC cutoffs for 2 tests. I don't have enough time to spend on this, but read little bit about this, that what is an ROC curve and where all it is used. So overall accuracy of a diagnostic test, comparing 2 tests, and to choose a cutoff point. Okay. So last question. What is the color code of the waste bags used in each situation? Broken glass, placenta, syringe without needle. At least give me one answer. Placenta. Okay, I think some of you have answered placenta yellow. Excellent. Broken glass blue. Perfect. Okay, nice. Good. Nice. And from the earlier, both Pranav and Rani had answered the 2 positives. Very good. Alicia said ROC. Okay, good. Someone attempted earlier questions. Nice. So I think all of you got it correct. Okay. Broken glass blue, placenta yellow, syringe without needle red, gloves go into red, and again PP aprons and mask go into yellow. Okay. Very easy. Spotter, what is this? What is this test? And describe the lesion. Very good. MCUG. And what grade of MCUG? All of you are writing correct. MCUG. Okay. Fine. The obvious questions which can be, how will you manage and what is the follow-up plan? Please read and prepare for that. Okay. Yes, sir. That's it from my side.
Yeah, that was a quite a wonderful OSCE into the statistics. That was really good. Thank you, Dr. Sai Kiran, for such very informative OSCEs. And thank you for sparing your valuable time out of your busy schedule. Thank you, and thank you all the students for presenting interesting cases. I think you need to be more active